welcome to this explainer. Have you ever stopped to think about how much of a medical mystery is literally hiding in plain sight? I mean, a routine urinalysis might seem incredibly mundane, just a standard, boring part of a checkup. But it's actually a high-stakes, absolutely fascinating detective story about the human body's internal plumbing. Today, we're going to learn how to read those microscopic clues and decode that exact story. Okay, let's dive right in. Here's our diagnostic roadmap for today. We'll start by decoding the dipstick. Then we'll examine the microscopic clues, move on to molds and stones, and wrap it all up with the hematuria mystery. It's a step-by-step process to crack the case. Section 1, decoding the dipstick. Let's step directly into our crime scene by looking at our absolute first line of investigation, the chemical clues. You know, when you dip that stick, you aren't just getting one simple answer. You're gathering a massive array of initial chemical clues. We're testing for specific gravity, pH, protein, blood, bilirubin, leukocyte esterase, and ketones. The sheer volume of things this one little strip tests for is incredible. It provides immediate red flags for everything from diabetes to severe liver disease. Let's break down one of the most foundational elements on that strip, and let's eliminate the jargon right away: specific gravity. Simply put, this is just a measure of urine concentration, or its heaviness. It's directly tied to the body's hydration levels and a little something called antidiuretic hormone, or ADH. It basically tells us how much water the body is actively trying to hold on to at that exact moment. And we can starkly contrast these two states. A high specific gravity, that means your body is pumping out ADH to desperately hoard water. Think severe dehydration, congestive heart failure, or cirrhosis. Sometimes even excess glucose acts as a solute, making it heavy too. On the flip side, a low specific gravity means the urine is super dilute. This happens when the kidney tubules are damaged, like in acute tubular necrosis, or when the body completely ignores ADH altogether, like in diabetes insipidus. Now let's move to pH, which can also swing to wild extremes. A low pH means the urine is highly acidic, and that creates the perfect environment to form uric acid, calcium oxalate, or cysteine stones. But a high pH tells a completely different story. What's really interesting here is that it often points to urease-producing bacteria, like Proteus. These bacteria literally convert urea into ammonia. They raise the pH and build massive struvite stones, which can sometimes lead to those nasty staghorn calculi, giant stones that can fill the entire kidney. Section 2, the microscopic clues. We've gathered our chemical evidence, so now it's time to zoom in and shift our focus to the physical shapes under the microscope. So the crucial point to understand is that shape is a massive clue when we find blood. If we see normal, perfectly round red blood cells, the bleeding is likely coming from non-glomerular issues lower down in the urinary tract. But if we see dysmorphic cells, specifically these oddly shaped ones called acanthocytes, it proves those poor cells had to violently squeeze their way through a damaged glomerular basement membrane high up in the kidney. We've also got to look out for other cell types. Finding lots of white blood cells literally screams infection. Or if they're a specific type called eosinophils, they point to acute interstitial nephritis, which is essentially an allergic reaction inside the kidney. But, and I have to warn you about this, you must watch out for squamous epithelial cells. If you see too many of these flat skin cells, it means the sample was a dirty catch. It completely muddies our clues and we'll probably need to repeat the test. Section 3, molds and stones. Now we transition to some of the most visually distinct and, honestly, coolest evidence in our detective story: casts and crystals. So let's define what a cast actually is. A cast forms when cells or proteins get stuck in the kidney's tubules. They clump together and form a literal physical mold of that tubule's specific shape. The crucial point here is that finding a cast absolutely proves the pathology is happening high up in the kidney's pipes, rather than lower down in the bladder. And we can methodically map these casts to specific diseases. Red blood cell casts, that means glomerulonephritis, a severe inflammation. White blood cell casts indicate a kidney infection, like pyelonephritis. Hyaline casts suggest a pre-renal issue, like hypovolemia, basically low blood volume. But the absolute smoking gun for acute tubular necrosis, spotting a muddy brown cast. It's literally made of dead, sloughed-off kidney cells. And this brilliantly illustrates how connecting geometric shapes to stone types makes diagnosing nephrolithiasis highly visual and intuitive. An envelope shape? That means calcium oxalate. A wedge is calcium phosphate. Rhomboid points to uric acid. Hexagons are cysteine stones. And that ominous coffin lid appearance? Yep, that's your struvite stone we mentioned earlier.
It's like a giant puzzle.
Section 4, the hematuria mystery. Welcome to the masterclass segment. We're going to combine everything we've learned so far to crack the ultimate clinical case, hematuria, or blood in the urine. Now, we have to ask a really critical question right up front. Is all blood in the urine telling the exact same story? Well, as you might guess, the answer is no. Finding blood forces us down a complex, branching logic path to figure out exactly what is bleeding and why. The first step is splitting the diagnosis into two main camps based on our microscopic clues. First, glomerular hematuria. This features those dysmorphic cells we talked about, red blood cell casts, and heavy protein levels. We're talking often over 3.5 grams in 24 hours. This requires checking serology to hunt for systemic autoimmune issues, like lupus or ANCA vasculitis. Non-glomerular hematuria, on the other hand, features normal-shaped cells, zero casts, and sometimes big macroscopic clots. That points to a structural bleed, like a stone or a tumor. But hold on. Here is a fascinating diagnostic trap you absolutely must watch out for: pseudohematuria. Imagine this. Your dipstick reads incredibly positive for blood. You go to the microscope expecting a total bloodbath, but you see absolutely zero actual red blood cells. No way, right? Well, this happens because the chemical dipstick is reacting to circulating myoglobin from severe muscle breakdown, known as rhabdomyolysis, or free hemoglobin from red blood cells popping open during hemolysis. It's a tricky little fake-out. If we do confirm it's true, non-glomerular bleeding, we can often diagnose the location based purely on when the blood appears during urination. It's a remarkably simple but amazing clinical action plan. Bleeding seen throughout the entire stream points high up to the kidney or ureter. Terminal bleeding, which is seen only at the very end of urination, points to the bladder or bladder neck. And initial bleeding, spotted right as urination begins, usually pinpoints an issue in the urethra. Finally, we conclude the entire workup by matching the patient's symptoms to the right imaging tools. If a patient comes in with acute, agonizing flank pain and hematuria, a non-contrast CT scan is the gold standard to hunt for a kidney stone. But what if you have a high-risk older patient with a history of smoking who presents with painless bleeding? That is a huge red flag for malignancy. In that case, we need a CT urogram, a cystoscopy to visually look inside the bladder, and cytology testing to hunt the urine for actual cancer cells. And that brings us to the end of our investigation. The sheer complexity and branching logic hidden inside this everyday medical test is just astounding. So the next time you look at a routine lab result, ask yourself, what hidden microscopic story is it waiting to tell you? Thanks for joining me on this explainer. Keep asking questions and keep exploring.